Hi, and welcome back. Again, my name is Maureen Oscadal, and I'm a registered nurse based in Seattle, Washington. I work here with the University of Washington's Addictions, Drug, and Alcohol Institute, and this is the Nurse Care Manager Foundational Series. In this next video, we're going to talk about opioid use disorder care management, focusing on the role of the nurse care manager and team-based care. We'll get started now. So opioid overdoses continue to be a significant health problem in our country. As shown here, in 2021, an estimated 80,000 people died due to opioid overdoses in the United States, and that's an increase of about 17% from the previous year. So what can be done about this? Well, as we've covered in previous videos, medications like methadone and buprenorphine are effective, life-saving treatments that evidence has shown to reduce all-cause and opioid-related mortality. And yet, access to these medications continues to be limited. As we see here, only about 1 in 4 people living with opioid use disorder in the United States receive medications for opioid use disorder. Access to these medications is a significant problem. Expanding access and making treatment more available is incredibly important. And so the idea behind collaborative care and team-based care is that a team can help to improve access to medications for opioid use disorder by increasing the capacity of prescribing providers to make treatment available to more patients. As the saying goes, many hands make good work. We're going to review some of the approaches to collaborative care now. But first, who is actually on the team? Teams can involve a lot of different roles, and this can vary based on setting. One of the most important members of the team, arguably the person that needs to be on the team for it to even function, is the patient. Then we also have providers, pharmacists, care navigators, peer support specialists, nurse care managers, social workers, and mental health counselors. This list certainly isn't exhaustive. Are there other roles that you work with that aren't listed here? Who are they, and how do they function and support the team? And here we see a mapped layout of how collaborative care can work, with some of those team members that we previously mentioned listed here. And in this particular care model, the patient is directly supported by the prescribing provider, a navigator, and a care manager. And in the background, you can have addiction medicine and psychiatry consulting providers available to provide support and guidance as needed to the prescribing provider and care manager. So this is one example of a team-based approach that increases the prescribing provider's capacity to provide more holistic care to their patients. Another model of care is the Massachusetts model, which aims to increase access to medications for opioid use disorder in office-based settings. This model is multidisciplinary and uses nurses in care management roles to make opioid and other addiction treatment available in office-based or clinical settings. Many of the office-based opioid treatment teams, like the one I work at Harborview, have been adapted after this model. The Massachusetts model involves 3 general steps. First, assessment. Second, medication initiation and stabilization. And third, maintenance. In each step, designated members of the team are engaged in specific activities to help the patient engage in medications for opioid use disorder treatment. Throughout the process, the nurse care manager is involved and provides continuity of care. The Massachusetts model has been studied over the years and has been shown to have the following benefits. It provides a support structure for providers to prescribe buprenorphine in primary care and other clinic settings. And the office-based setting can provide a level of privacy and convenience for patients that they may not find in other more traditional addiction treatment settings. The office-based setting also facilitates preventative care and treatment of other health conditions. and it can provide the opportunity to engage and offer medications for opioid use disorder to non-treatment seeking patients. Finally, the 12-month retention and care rate has been as high as 54%. Another model of starting medications for opioid use disorder and transitioning to outpatient care happens in the emergency department. In this model, patients are identified when they present in the ED, and they are started on medications for opioid use disorder if they want. This model can involve nurse care management and care navigation to assist with medication support and warm handoffs to outpatient care. Regardless of treatment readiness, this model aims to provide every patient with a brief intervention, overdose education, and naloxone. A third model of care is sometimes referred to as low barrier treatment, and it applies principles of harm reduction when offering and managing medications for opioid use disorder. This approach makes medications available to people living with opioid use disorder if they want it, regardless of other circumstances, including ongoing substance use. The goal of the approach is overdose prevention through engagement, and this is achieved by lowering barriers to treatment access. Care is provided by a multidisciplinary team, including prescribers, nurses, social workers, case managers, care navigators, and peers. Making care available where patients are is important, and outreach is common. All right, so moving on, now that we've reviewed some, but by no means all, of the care management models, we're going to move into what care management can look like. And here we have listed the 4 stages of medications for opioid use disorder, or MOUD, treatment: assessment and intake, MOUD initiation, MOUD stabilization, and maintenance. We'll go over each of these in some detail next. So in the first stage, assessment and intake, the nurse engages the patient in a discussion about the patient's goals and their hopes and motivations for treatment. The nurse can also gather a health history at this time, do some medication teaching, and review programmatic and/or clinical policies, resources, and expectations. In the second stage, medication initiation, the nurse engages the patient in education and shared decision-making about how to start the medicine. As you'll recall, there are several different ways for starting buprenorphine, and shared decision-making is a process that allows patients to choose the approach that's best for them. If you want to review the different ways that buprenorphine can be started, refer to the previous video. The nurse should counsel patients about what to expect when starting the medication, including how to manage withdrawal symptoms, as well as what they can expect to feel in the first days and weeks of treatment. When the nurse and the patient are planning the medication start, it's good to know when the patient thinks they might begin the medication. This can be based on their school schedule, work schedule, or other day-to-day activities. Then, based on when they think they're going to start the medication, it's important to schedule follow-up. This can include a time to check in 1 to 2 days after the patient plans to start, as well as an appointment that aligns with when their next prescription will be due. In the third stage, stabilizing on medication, one of the nurse's primary tasks are to monitor medication effect and adherence. This can be done by assessing withdrawal and craving symptoms, as well as ongoing substance use. Other ways to monitor adherence are to ask about how the patient is taking the medication. For example, how many days do they take the full prescribed dose, and how long does it take for the medication to dissolve under the tongue, as well as whether the patient feels like the dose is effectively managing their symptoms. If the patient continues to use or has returned to using substances, it's helpful to understand if there's anything they want to change about their use. But it is also important to continue treatment as long as it is providing medical benefit, which is generally determined based on patient report. During this stage, it can be helpful to review how the current level of treatment is working for the patient. And if the patient and nurse feel like additional supports might be helpful, it's good for the nurse to be able to provide referrals and warm handoffs to supports like mental health care, peer support, or recovery support meetings. During this stage, the nurse is likely seeing the patient more frequently, either in person or via phone check-ins. And typically, it's helpful to schedule those follow-up visits based on when the patient is due for their next prescription. The fourth stage is maintenance. And in this stage, the nurse's role is to continue to monitor treatment and support the patient. At this stage, follow-up visits may become less frequent as intervals between visits lengthen in duration. As in all stages, it's important to highlight and celebrate positive health behaviors. It's equally important to avoid judging or shaming a patient if they experience a return to substance use, but rather to frame that as a learning opportunity and offer increased support while maintaining focus on the patient's goals of care. Next, we're going to talk about two special clinical situations that the nurse care manager should be prepared for with patients who are taking buprenorphine. And the first is pregnancy. Some of the main points are listed here, and they include, first, that buprenorphine should be continued. If a patient becomes pregnant and they are on buprenorphine already, that medication should be continued. And patients should be educated about the risks that withdrawal symptoms pose to the pregnant person as well as to fetal development. In the past, recommendations were to transition pregnant and breastfeeding people from buprenorphine naloxone to buprenorphine only, or subutext. However, this isn't always necessary. The risks and benefits of which formulation to use should be discussed with the patient and their prescriber, and shared decision-making should be practiced when making the formulation choice. Second, the nurse care manager should try to connect the patient to an OB/GYN provider with knowledge about opioid use disorder and medications for opioid use disorder. At the very least, it's important that this provider be aware of and in support of the plan to continue medications for opioid use disorder. Finally, it's helpful to talk to patients about any previous experiences they've personally had with opioid use disorder and pregnancy. It's also helpful to consider and prepare the patient for the different systems that they may engage during and after their pregnancy. Another clinical circumstance that can come up is planned surgery. And in these situations, if a procedure is scheduled in advance, the following steps can be helpful. First, ask the patient what they prefer in terms of pain management. Keep in mind that not all patients are comfortable with full agonist opioids, and some may prefer to pursue alternative options if possible. This brings us to the second point, which is practice shared decision-making when determining the pain management plan. This should be done in partnership with the patient, their prescribing provider, and the surgical team. There are different approaches to managing medications for opioid use disorder prior to, during, and post-surgery. Often, however, it's possible to continue buprenorphine with the dose unchanged and to treat the acute surgical pain with a short-acting full agonist opioid. Finally, explain to the patient and be prepared to educate the healthcare team that medication dosing, specifically pain medication dosing and frequency for people with opioid use disorder who are taking medications for opioid use disorder, may look different than for other patients, but that adequate pain management is as important for people with opioid use disorder as it is for people who do not have opioid use disorder. So as we wrap up, let's discuss team support. One recommended approach to supporting team-based care is to hold regular team meetings to share highlights, programmatic updates, and evolving best practices. These are also important opportunities for members of the team to consult about patient care, which can help to ensure that treatment changes are collaborative. These meetings also provide a forum for collecting input from team members with different roles and perspectives. When teams meet to consult about challenging patient cases, they should focus on strategies that aim to maintain patient engagement and continue medication for opioid use disorder. Some of the ideas that might be suggested during these team meetings to bolster patient care include considering the medication dose and whether an increase is appropriate, referring to mental health or recovery support, involving partners or loved ones in the process, offering more frequent follow-up, or if the patient is willing, transferring care to another program that provides a different level of support, or to a program like an OTP that has methadone available. In the work that we do, team-based care benefits staff and patients in a number of different ways. It enables staff to work within their scope while performing complementary tasks to improve health outcomes. It improves patient access to medications for opioid use disorder. It reduces the risk of staff burnout, and it helps maintain consistency in terms of practice across providers. Of course, there's also challenges to working on teams. Some that might come up include finding the right team members, building trust with patients, and finding time to meet and communicate as a team. Addressing these challenges and creating a positive team culture does take work. It involves an emphasis on shared decision-making, taking time to discuss and agree on a unified team philosophy, and ultimately approaching patient care from a we rather than a me perspective. This concludes the video about care management and team-based care. Thank you for joining me. In the next video, we will cover ongoing and return to substance use.